and I'll be today's host. To introduce him, Dr. Block is a general adult and pediatric otolaryngologist and an ENT surgeon in Garden City, New York. Dr. Block completed his residency at Georgetown University Hospital, where he was appointed administrative chief resident and received awards for research and leadership. He's also the host of the podcast Physician Guides to Doctoring and guides healthcare practitioners looking to improve in any and all aspects of their lives and practices. Before we begin, we have a couple of reminders for everyone. We encourage you to turn on your cameras if you're able to. This session will be recorded and uploaded to our YouTube channel, and there is a Q&A at the end of the session. For any questions you have, you can feel free to unmute at that time or write in your questions in the chat at any time, and we'll cover them during the Q&A. But with that said, Dr. Block, feel free to take it away.
Thanks a lot for listening. And for that wonderful introduction, Michael. For when you do have questions, please call me Brad. I'm not your attending. I'm not your personal doctor, so we can keep this casual. Quick plug for myself. I am the host of the Physician's Guide to Doctoring podcast. The whole point of the podcast is to steal something from Ted Lasso to help physicians be the best they can be, the best versions of themselves in and out of the exam room. So if you're wondering about different specialties, some of my episodes, I have specialists come on to talk about what they like, or not what they like, but rather what they want every other doctor to know about their specialty. So, for instance, I gave some medical students at the NYU Long Island School of Medicine a lecture on ENT within the primary care clerkship, but most of the other stuff that they're getting from about ENT is from primary care physicians. So sometimes you get different information from hearing it from the specialists themselves. Which is kind of why all of you are here, to find out what my specialty is all about. So otolaryngology, sometimes called otorhinolaryngology, sometimes called ENT. It's all the same thing. We're all surgeons. So all ear, nose, and throat doctors are surgeons. Some of us do more surgery and some of us do less surgery, but we're all trained to do surgery. And actually, our training is predominantly surgery. The interesting thing is, as a private practitioner myself, I spent 4 out of 5 days a week in the operating room in my training, and now I spend 4.5 days a week, maybe 4, in the office, and maybe a half day or a full day in the operating room. So there's much more office hours in practice than in training. But it also speaks to the difference between private practice and tertiary care, right? When if you're going to a tertiary care, an academic center, the way that they see patients is it's a funnel for complicated cases. So they get a lot of their cases from the community ENTs, and so these are inevitably going to be more complicated and likely to require surgical management, so that just the referral patterns ultimately influence how your practice goes. So let's talk about the specialty a little more, right? What is ENT? So to give you a sense, there are a bunch of subspecialties of ENT, right? You can do a fellowship afterward, and the fellowships are in facial plastic surgery, rhinology, otology, sometimes called neurotology, pediatrics, head and neck cancer. I think that's all of them. Basically, ear, nose, throat, kids, adults, cancer. So, not adults rather, but kids, and then head and neck cancer. So some of us really practice the wide gamut of that when we're generalists. Like I was speaking to a physician the other day, practiced in Alabama, and the day after I was speaking to him, he was doing a neck dissection for cancer, followed by a cochlear implant. My day looked a little different. I had office hours consisting of postnasal drip, nosebleeds, earwax, nasal congestion, runny noses, throat clearing again, and dizziness. So, two very different practices. And one of the things that you'll realize as you continue your training is just within each specialty, how different a practice can be. Like the life of a head and neck cancer surgeon is very different from the life of an otologist who spends their time doing cochlear implants, working up dizziness, maybe acoustic neuromas, stapedectomies, chronically draining ears. And those, if you do, say, a fellowship, your life is going to be very different if you go into private practice versus academics. So there's often a lot of stress around choosing a specialty. And my wife won't appreciate me saying it like this, but I'm going to say it anyway. It's like choosing a spouse. If you think that there's one out there, only one in the world, that's the right one for you, and everyone else is wrong, then you're just wrong. That's not the way to think about it. There are a bunch that you're going to be really unhappy in. There are a bunch that you're going to be kind of happy in. And then there are a bunch that you're going to love. Maybe some a little more than others. But don't put so much pressure that there's like this one right one out there and everyone else is wrong. Like, I'd be perfectly satisfied being an ophthalmologist. I'd be perfectly satisfied being a urologist, an anesthesiologist. But there are other things that I wouldn't want to deal with. And even as an ENT, one of my friends is a head and neck cancer surgeon. So he spends most of his days in the operating room doing complicated surgery. So his life is actually more similar to a general surgeon or even a gynecological oncologist than it is to me. He said, if I have to spend my days taking out earwax, I'm just going to quit. So he doesn't. I do. And I'm perfectly satisfied with that. You know, they walk in, I can't hear. I think I'm losing my hearing. And you take out a big hunk of wax and they're like, oh my God, I can hear again. It's a miracle. So, right, it can be even the simplest stuff can be satisfying. Okay, so let's talk about the conditions that we treat within each specialty, right? So you've got rhinology, rhino, nose. So they do sinus problems and sinus cancers. So some of the problems that they treat would be nasal polyps, chronic sinus infections. Often we treat that with surgery. They'll treat cerebrospinal fluid leaks. So you can get a CSF leak through your nose. It'll present as unilateral rhinorrhea. So one-sided runny nose. Or tumors of the sinuses, which sometimes require endoscopic approaches, sometimes require a mixed approach, where you'll actually have to make incisions in the face to gain access. So that's rhinology. Okay, facial plastic surgery can be different depending on who you are and where you are. So that might be cosmetic surgery. And if I can take a little dig at my plastic surgery colleagues, you know, ENTs really do most of the plastic surgery on the face. And we're called facial plastic surgeons. Plastic surgeons are general plastic surgeons. ENTs are facial plastic surgeons. So an example would be a facelift. When we're doing a parotidectomy, so we're removing a tumor from the parotid gland, the first thing you do is you find the facial nerve, right? That gives the muscles of facial expression, creates the movement of the muscles of facial expression. So you find it so you're not damaging it, and you remove the parotid tissue between the nerve and your skin flap. In a facelift, you're making a similar parotid incision. You're dissecting under or over the parotid. You're not getting anywhere near the nerve, and then you pull back some of the tissue and sew it back. So the facelift is like the easiest part of the parotidectomy. Now, granted, there's more to a facelift than that, but I'm just saying the ear, nose, and throat doctors really should be doing the facelifts. Just saying. Okay, so a facial plastic surgeon will do something like that. They'll do lid lifts. They'll do rhinoplasties. They'll sometimes do Mohs reconstructions, where a Mohs dermatologist would have removed a large amount of tissue from the face, and it's up to the facial plastic surgeon to rotate in tissue in such a way that there's a minimal defect. So that's what some of the facial plastic surgeons do. What other facial plastic surgeons do is they might do some of that, but they'll also do reconstructions after head and neck cancer surgery. So I have a patient who's actually going to be having, I don't do cancer surgery anymore, so I send him to a head and neck cancer specialist. He's going to be having a good portion of his tongue removed and lymph nodes removed from his neck. And in order to reconstruct some of his tongue, they're going to be taking tissue from his forearm, It's called a radial forearm free flap. They're removing it with its blood vessels, so the pedicle that has the artery and the vein. They're putting that into the blood vessels of the neck, and they're putting sewing his forearm onto his tongue. Incredible. It's an incredible thing to do that I helped with in my training, but then, once I was done with my training, you really need to have done a fellowship in order to do free flaps. Free flaps are where you're doing a free tissue transfer. You're taking it from one part of the body. They'll take it from the calf. They'll take it from the forearm. Sometimes they'll take intestine even, and they'll use it to create new tissue to fill in the tissue defect. So some facial plastic surgeons will do that. They'll do the reconstructions after head and neck cancer surgery. Which brings us into head and neck cancer. So most head and neck cancers are squamous cell carcinomas. They can happen in the nose, the mouth, the throat. Just for everyone on here, make sure you got your HPV vaccine, because tonsil invasive tongue cancer is now predominantly caused by HPV, whereas it used to be caused by cigarette smoking. But nobody smokes anymore. They're all vaping. So you'll have to, any cancer in this area is going to be treated by a head and neck cancer surgeon. Now, there's an overlap between us and general surgery, because you can do a 5-year general surgery residency and then a 2-year head and neck cancer fellowship. Or you can do a 5-year ENT residency and then a 1-year head and neck cancer fellowship, because we do so much. You don't have to do a fellowship to do a lot of the stuff that I'm talking about, but if you're going to be going to an academic center, they're probably going to be looking for you to be fellowship trained. And also you'll likely end up just savvier in that area from more experience and likely exposure to a different program that may have different ways of doing things. Also do thyroidectomies, parathyroidectomies, salivary gland, like parotid and submandibular gland. And some of them will be comfortable with sinus tumors as well. Oh, I forgot to mention laryngology. So ear, nose, and throat. Laryngology is voice and swallowing. So you might have someone who specializes in or treats a lot of professional singers, professional voice users. They might remove smaller vocal cord cancers. They're probably not doing laryngectomies. That's going to be the territory of the head and neck cancer surgeon. But anything that they can remove endoscopically is going to fall into the realm of a laryngologist. So ear, nose, and throat is really where we don't have any overlap with other fields. But everything else we do, facial plastics overlaps with general plastics and oculoplastics. Endocrine surgery, thyroid, parathyroid overlaps with general surgery, as does, head and neck cancer in general. So, but if you're doing sinus stuff, only ear, nose, and throat doctors. Voice, swallowing, only ear, nose, and throat doctors, and ears. So what does an otologist do? So otologists treat chronic ear infections that might, we all, chronic ear infections, we just put tubes in, which any ear, nose, and throat doctor should be able to do blindfolded with their non-dominant hand. But, so if you're an otologist, you're going to be removing cholesteatomas, where you're actually making an incision behind the ear canal, behind the auricle, raising up the ear canal and drilling out the mastoid bone. And you've got to watch out for the semicircular canals, the facial nerve. There's a lot that you need to tread lightly around, the skull base. So that's hard to do. And it's very different from what you'll be doing in the rest of what ENTs do. You're using a drill instead of a scalpel and a scissor and a freer elevator. So you're really doing things that are very different. They actually use the sound that the drill makes, the whine of the drill, to help them know when they're getting close to dangerous structures. It's really quite incredible. So they'll remove cholesteatomas, acoustic neuromas, where you're assisting neurosurgeons in getting to that. You might be putting in cochlear implants, and then you're working up dizziness. So dizziness is inordinately complicated. Those patients can be very easy to treat if it's something like benign paroxysmal positional vertigo, where you're doing the Epley maneuver. And if you don't know what that is, it's basically magic. So people will come in saying that they feel like the room is spinning when they lie down and turn to one side. They feel the room spinning around. They think they're having a stroke. And it happens every time I turn to this side. What the heck is going on? So as it turns out, the semicircular canals, which are the part of the inner ear, you'll have a loose calcium crystal in there. And so as you turn your head, this crystal starts falling around the loop, telling your brain that your head is turning. So what we do is we turn the head in a couple different ways, something called the Epley maneuver, and we get that calcium crystal to just leave that chamber so it's not bothering the patient anymore. So it's like we're chiropractors, only not pseudoscience. Sorry. Had to take the shot when I had the opportunity. Okay. So sorry if anyone's pre-chiropractic on the phone, on the line. So as a general otolaryngologist, I treat a lot of this myself. As you can see, the great variety of stuff that we do, right? Like one of my patients might be a 2-year-old recurring ear infections who I plan on taking to the operating room to put ear tubes in. And my next patient might be a 98-year-old woman with difficulty swallowing. So I have plenty of patients where I take care of 3 generations of the same family, which is a great feeling, right? That they trust you with their elderly parent. They trust you with their child. And then you get to know them. There's a lot of continuity of care. A lot of times if your sinonasal mucosa doesn't work well, you have ear problems. You probably have a little bit of asthma. You have sinus problems. You might develop nasal polyps. These are lifelong patients. And they come in with one thing when they're younger and another thing when they're older. So, a lot of people go into family medicine because they're like, there's continuity of care and I get to see everyone from little kids to adults, but you do that in ENT too, if you're a general ENT. Now, if you're subspecialty, you give up some of that. Pediatrics, you're doing tubes, tonsils, and adenoids like I spend a lot of my day doing, but they'll spend some of their time doing laryngotracheal reconstructions, subglottic stenosis. Kids can't breathe because they have a tiny little airway. So they've got to make an incision, pull out the larynx and trachea and actually put in a rib graft or a cartilage graft in order to widen it. You're really doing a pediatric fellowship if you want to do the complex pediatric airway surgery. Some of the pediatric ENTs are comfortable with chronic ear disease. So they might be doing mastoidectomies on kids. Or they might be doing cochlear implants. It's rare that a kid needs a mastoid, but they might be doing cochlear implants. They're also doing some head and neck surgery because kids get thyroglossal duct cysts. So they're doing some open neck surgery. Kids might come in with parotid masses too, and it depends on what your comfort level is. You might send that to your head and neck colleague or you might do it yourself. So I think I covered all of the subspecialties within ENT. In terms of training, it's 5 years. Intern year used to be kind of separate. Then it's now part of the residency program. So you're just applying to one residency program. And like my intern year, I spent a month on transplant and a month on urology, 2 things that have nothing to do with otolaryngology unless you're doing face transplants, where they're doing in like 2 academic centers in the world. So not really much applicability to my life. But now it's owned by the otolaryngology program directors have a lot more say, so they can make sure that their residents are actually getting trained in things that are applicable to their field. It's competitive. It's one of the most competitive specialties out there. And so what I tell my students, I probably don't have as good advice as other people that you're going to have on the podcast, but they want to make sure that you're smart, you're dedicated, you work well with others. Away rotations mean a lot, so you got to do away rotations. I matched at Georgetown where I did an away rotation. I went to medical school in Buffalo where there was no residency program at the time. So I did a rotation at my home program because you have to, and then I did 1 rotation at Georgetown, and that was where I happened to match, and it has to be because of my performance on the away rotation. Because otherwise, it's really hard to tell the difference between students on paper. You're all going to be pretty incredible on paper, and some of you are going to be pretty incredible in real life. Okay, I'm kidding. I'm sure all of you are wonderful in real life, but You get what I'm saying? Like, between the scores and the grades and the letters of recommendation, it's really hard to separate great students from great students. So, scores and research. Don't hate the player, hate the game. You got to do your research. They want you to be someone who is contributing to the field. And they want you to be someone who's going to be the next chairman of their department or another department. That's what they take pride in. How many department chair people they produce. So they don't want you saying, oh yeah, I plan on going to private practice. Oh, I plan on doing facial plastics. I want to open up the next Juvederm Botox rhinoplasty place in Beverly Hills. No, that's not what they want to hear. They want to hear that you're going to be staying in academics. You love research. You want to contribute to the betterment of the specialty. I'm not saying that you shouldn't be honest about it, but take the advice as you would. That's really what they're looking for. At least they were 15 years ago when I was applying. So that's it about my specialty. At least what I'd plan on telling you what ENT is all about. So let's go to the questions. Chat. Where's the chat? Okay. So please put them here and we'll address them during the Q&A. So Michael, is there anything else that you would want me to talk about before we move on?
Yeah. So like you said, if there's anyone who has any questions, feel free to put them in the Q&A. But maybe a few things that we can further discuss. So you have your own podcast, right? For
Yes.
those who might be interested in hearing more from you, what does your podcast entail? What do you discuss, and how does that apply to the pre-med community?
So I'm sure all of the episodes don't apply to the pre-med community because my audience, my avatar is other physicians, other attending physicians. But there's certainly things that I have interviewed guests about that would apply to anybody. For instance, I interviewed have you guys heard of The Onion? The Onion. So Scott Dickers is one of the founders of The Onion, and he wrote a couple books, How to Write Funny, How to Write Funnier, and How to Write Funniest. So I had him talk about how to be funny with your patients because it's important to engage with them, and it's a skill that you should practice. It can really help with engagement, with patient satisfaction. It can even improve outcomes because it's going to help you with your rapport. Like I had a patient today that was telling me that their doctor, they felt like they were seeing another specialist, not an ENT, for something different, and they felt like the doctor knew what they were talking about but really didn't listen to them. I said, you have to find another doctor then. If you feel like they're not listening to you, that's so critical to the relationship, and it's important to outcomes. So, I can make some recommendations. So, you shouldn't get in the habit of pulling people away from doctors that they're seeing, but right? The relationship matters. And so humors are going to be important to the relationship. So how do you make a joke? How do you joke around with your patients? If you tell a joke that bombs, how do you save it? Right? So once you're with your patients, once you start medical school, you're going to be exposed to patients and you should enjoy it. And if you can joke around with them, then they're going to enjoy it more. They're going to like you. They're going to tell your attending how much they like you and what a great job you did. So for instance, something like that. I've had someone who's a PhD in health policy, also happens to be my brother, on the podcast a few times to talk about health policy issues. Like at the beginning, we talked about what everybody needs to know and often gets wrong about the Affordable Care Act. When people were running on the Medicare for All platform, we talked about what does that even mean? Turns out it's more of a tagline than a really a meaningful statement. So we talked about what it means. So these are things that physicians should know, but it's important for you guys to be able to know these things and talk about them eloquently. And what better way than to just listen to a podcast for consuming information. So those are two examples. And again, also I have specialists on that talk about things relevant. So I did a whole episode where someone interviewed me on the workup of dizziness, but just not the nitty gritty of it, the stuff you're going to need to memorize for your shelf exams, but rather how to conceptualize it. So if you're an urgent care doctor and you're seeing a dizzy patient, where do you even begin? So for you guys to hear stuff like that, it's going to be a good foundation to build off of.
Definitely. We actually have now a few questions here. The first being, what are some of the most important qualities you believe someone needs to have or be prepared for that ENT surgery, to go into ENT, the specialty, based on your own personal experience in the past?
So specific to ENT surgery, I mean, I don't know if there's anything that really sets ENTs apart from other doctors and other proceduralists. Right? Like what makes us different from other doctors? I think one thing that makes us different from other doctors would be just the wider variety of things that we treat, right? Like drilling out a mastoid versus endoscopic sinus surgery versus open neck surgery versus working up patients in the operating room. You really need to be able to be comfortable in all of those settings. You need to be confident, because during your training, what's going to happen is you need to be able to be confident to operate, to do procedures every time you have the opportunity to do it. And you're going to learn and you're going to get better. Because if you're hesitant, then you're not going to get that opportunity and you're not going to be able to get better. So you need to be able to get in there and assist and assist and assist and assist and do and do and do. Because if you're like, I'm not sure I'm comfortable doing that, well, then you're missing out on that opportunity. And then the next time that opportunity comes up, you're not going with that experience that you just had the previous time. So the experiences build on each other. And so the more confident you are in your own abilities. And so how do you get there? Practice, right? Be that person that's tying knots. I'm not sure how much dissection on, if you have any opportunities to practice in other settings, I would say take those opportunities. Let me think. Yeah. Confidence, that's in order to get you to be a competent surgeon. But I think having those, again, this is what I cover in my podcast, having those soft skills that allow you to connect to your patients is going to be important to figuring out the diagnosis. Because when you're an ear, nose, and throat doctor, it's not like a cardiothoracic surgeon has the cardiologist. A neurosurgeon has the neurologist. We have no equivalent for the medical versus the surgical management. You are the medical and the surgical management. And so you need to be able to build rapport with your patients. So I think working on that. And if anyone's familiar with Carol Dweck mindset, like you need to have a growth mindset. You need to realize that like if you're not a funny person, you can learn to be funny. If you're not an outgoing person, you can learn to be outgoing. If you're not good, if you have some social anxiety and you're maybe not so adept at engaging with people socially, these are learned behaviors. They can be learned. They can be worked on. They can be practiced. And so doing these things is going to help you, because the more you can get better at engaging with your patients, the more likely you're going to get information out of them that's going to help you identify the diagnosis, and then also, again, establish that trust that then is going to get them to follow your recommendations. I mean, I'm speaking about it more from the perspective of an attending than a trainee, but it really applies to both.
Sounds good. Another person asks about the procedure you were talking about earlier, where you took out a crystal from the ear for a patient who was feeling dizzy. They're curious to ask, how does that exactly work?
Okay. So it's not, so first there's the ear canal, right? There's the auricle, which is the thing on your head, right? The thing that we put our mask loops over and our glasses, and our patients with hearing aids put their hearing aids over it. So we're really asking that thing to do a lot. But that's called the auricle, A-U-R-I-C-L-E. Then you've got your ear canal. And then you've got your eardrum. The top layer, the outermost layer of the eardrum is skin. So everything from the eardrum out is skin. So if you're having problems there, you're likely having skin problems. For instance, you can have eczema of your ear canal. You can have a wax impaction. That's ultimately a skin problem because wax is created by the skin. You could have swimmer's ear, which is a skin infection, right? Okay, now you've gotten deeper than the eardrum, you're gotten into the middle ear, right? This is lined with mucosa and connects to the back of the nose through the eustachian tube. The eustachian tube is the thing you can shoot air up when you hold your nose and blow. Conceptualize that more like one of the paranasal sinuses, like your sinuses, like when you get a sinus infection. It behaves more like the sinuses than the ear canal. So think of the middle ear like another one of your sinuses. And if you do that, it's going to help you remember what the 3 most common causes of sinus infections are, which is strep pneumonia, Moraxella catarrhalis, and Haemophilus influenza. It's not going to be on your test, but when you're a medical student, it'll be on that test. 3 most common causes of middle ear infection, 3 most common causes of sinus infections. So the middle ear mucosa is identical to the sinus mucosa, and they behave very similarly. You can get fluid in your sinuses, you can get fluid in your middle ear. When that happens, it's usually after a cold. So sinus infections and middle ear infections are secondary infections. So that's the middle ear, okay? Now that's where the ear bones are as well, right? The ossicles. Now you've got the inner ear. And the inner ear consists of the cochlea and the membranous labyrinth, which are the semicircular canals. So you have 3 semicircular canals, which are orthogonal to each other. Okay, it's a good word for you to look up, orthogonal. It means that it's like the corners of a cube. They're all 90 degrees to each other in 3 dimensions. And so there are calcium crystals that line the semicircular canals as well as are in the cochlea. And what can happen is one of the otoliths, these stones, calcium crystals, can leave the cochlea and get into the semicircular canals where it'll rattle around. So it's not like I'm removing a crystal from someone's ear. If I drilled into the semicircular canal in order to retrieve a crystal, by drilling into the semicircular canal, you'd make the patient immediately deaf and they lose all sense of balance. So you're not doing that. What you're doing is you're just rotating their head, kind of like those games that you might have had where you've got like a little metal bead and you've got to like move the maze around in order to get it from one place to another. That's kind of what you're doing with the semicircular canals. You're just getting that otolith to leave what is likely the posterior semicircular canal into a place where it just doesn't bother the patient anymore. So, okay. Does that answer the question? Clear as mud?
Yeah, I think that answers the question that we had here.
Okay.
Another student also asks also about how, another thing operates with the cochlear implant. How does that work, and how does that help patients recover from ear difficulties?
Okay, so cochlear implants is for deafness. So if you have no hearing or it's not serviceable hearing, which means that like you might hear, but it's not really well enough for it to be functional hearing, you can get a cochlear implant. It needs to be in someone that had hearing at some point. So if you were born deaf, you need to get a cochlear implant, I think within the first year or 2, so that the brain can develop the ability to understand the significance of the sounds. So we're using it for deafness. And what you do is the cochlea is that snail shell thing. So you drill into the cochlea to get an access point. Remember, I said if you drill into it, you lose your hearing. I said that with the semicircular canals, but the semicircular canals are confluent with the cochlea, right? That's all the inner ear. If you're going to drill into it for an access point and then put an electrode in there. And that electrode will go into that snail shell and then is going to stimulate it. So that gets connected to apparatus that goes underneath the skin, and then you get your processor that goes on top of it. And having seen one cochlear implant in residency, I'm not the best person to tell you how they work. But basically, it's an electrode that goes into the cochlea in order to stimulate it.
All right.
I can see the question, so I can do this. So how did you decide that medicine or ENT specialty was the right path for you? So like, how did I decide to go to medical school? Yeah, so that wasn't a great, this is not a great story. I just didn't know what else I was going to do with my life, and I was kind of good at science. So I did not start the path being pre-med. I had no intention of going to medical school. My major had me in all the pre-med classes, or a lot of the pre-med classes. So I already had those done by the time I decided to go to medical school. But, I had no path. And what medicine does is it gives you a path, right? A lot of our friends that don't choose something like medicine or law, where they just go to school and then apply for a job within that field, automatically having a profession, it's really hard for them to figure out where to go next and what to do. But we have this path. Not a great reason to go to medical school. But the other thing is I wanted my life to be dedicated to something of importance. And this automatically gives me something to do that's of importance. Not to say that other jobs aren't as important, because they are, and they actually can be more important. The reason I say this is because we treat one patient at a time, and we change outcomes one patient at a time, maybe, sometimes. But when you're deciding the health of a society, the influence of physicians on that health is not as great as you would think. So, we talk about social determinants of health have much greater impact. Public health has much greater impact than any single physician could possibly dream of having. So, but, gave me purpose, gave me direction. That's how I chose medicine. As far as ENT, one of my friends one day, who's actually one of my partners, is one of my friends from medical school, and now we work together, said to me, "Hey, you should check out this ENT thing. They do pretty cool stuff." So what I liked about ENT was never the big elaborate head and neck surgeries and reconstructions that ENTs do. It was more the slick stuff that ENTs do. For instance, there's something simple like an adenoidectomy. I remember seeing a kid. Actually, one of my kids right now is like that because he's got a cold and he's 2 and he can't breathe out of his nose at all. So when you see him eating his food, he's chewing with his mouth open because he can't breathe out of his nose at all. So he's barely eating anything since it requires so much effort. He can't drink his milk. He's struggling because he can't breathe out of his nose. So I see kids with adenoids that are huge and they're struggling, and I take them to the operating room for a straightforward, simple, low complication procedure, and they leave different kids. So it's a small intervention, and it ends up making a big difference. So there's a lot of stuff that we do in our field, like the Epley maneuver with the calcium crystal, right? It's high impact, high return on investment. But then the next question is, and also the variety, right? Like I said earlier, earwax one day, sinonasal surgery or sleep apnea surgery. Actually, that's another fellowship, not really popular, but some do a fellowship in sleep surgery. So sleep apnea the next day, just a frenulectomy on a 3-day-old for tongue tie, just a huge variety. What's the most interesting or favorite case that you've dealt with as an ENT? So actually, this was as a resident. The head and neck reconstructions are just unbelievable. What my colleagues do with free tissue transfers, like someone when they're having their tongue, part of their tongue removed, if you have to get to the back of the tongue, the only way to do that, now they're doing it with robotic surgery, but they used to do a mandibulotomy, where you're actually making an incision in the lip down into your neck dissection and then bringing all this tissue out. You're cutting into the mandible in order to swing the mandible open in order to get access to the back of the tongue. Now they can do it through robotic surgery, but when you see this person with like half their tongue removed, a lot of the tissue in their neck, they don't even look human anymore. And then by the end of the surgery, after the reconstruction, they're done, they wake up and they're not able to talk. They likely have a tracheostomy, but and they tend to recover pretty quickly. And then they're soon talking and eating, and you just saw them not so long ago, mid-surgery. It's incredible. It's an incredible thing to see. So again, it's not something that I do in my practice, because I'm not really doing cancer surgery anymore. But the most interesting thing is, I think, those heroic surgeries and reconstructions. Okay, next question. You mentioned that it's important to show that you want to contribute to bigger research in the future of otolaryngology as a practitioner. What is the current research surrounding the field, and how do you think what do you think this research will look like? What will it begin to address with the next generation of ENT surgeons? That's like way too broad of a question, because if the field of otolaryngology is so varied. Like, you really have to get more specific. If you're asking, like, what would be an interesting research project to get on, you're asking a guy in private practice that stops nosebleeds and removes earwax. You're asking the wrong guy, unfortunately. It's the academic centers where most of this stuff is happening. Some of the research that's changed the way I practice. One thing is the biologics, these antibodies for nasal polyps. So it's used for asthma, it's used for nasal polyps. And I've seen patients, nasal polyps can really be problematic in the more aggressive patients. And they need to, you take them to the operating room for multiple surgeries, and these polyps just keep growing back. They're inflammatory polyps. So they're not at risk for converting to cancer, but they'll block your nose. You can't breathe. You can't smell. They release inflammatory mediators in the bloodstream that aggravate asthma. And so we'll take you to the operating room over and over and over. We'll have you wash your nose out. Maybe we'll remove them in the office, but they just keep growing back. There's these antibody treatments, they're often called biologics, shrink these polyps, which is incredible to see. So you'll have patients that you've been struggling with for years, and suddenly they'll go in this twice monthly injection, and the polyps side effects are pretty infrequent, right? I'm not your doctor. This is not medical advice. If you plan on going on to the medication, consult your provider. But it's really changed the practice of otolaryngology for these patients. So that's an example of something that's just come about since I've been practicing. And remember, I'm only 10 years out from my residency training. So that's one example. And I'm trying to think of other things that have changed, but it's a relatively new area. Something that's important for you guys to think about. So I'll tell you a mistake that I made and something that you could do differently than what I did. So during my third year of residency, I spent 4 months doing a research project, and I had no idea where to begin. Just like I didn't know what I was going to do for a living, so I just picked doctor, right? Gave me a path. So I just went to one of the attendings that I was friendly with, great guy, and do you have any research project? So I did a little molecular biology research project, and it was awful. All this pipetting, right? It was torture. I didn't enjoy it. I didn't learn much from it. Didn't really produce groundbreaking research because I just relied on someone else. I didn't figure out what was my interest. What was I interested? And part of it was I was just so overwhelmed with residency. But when you're deciding, finding a mentor is hugely important because you really have to like your mentor. You got to look up to them. You're going to find mentors all over the place. It's important to have mentors, right? Find them. Find someone that you can look up to. You can even have multiple mentors at the same time, depending on what they're your mentor for. But if you're going to be doing some type of research, make sure it's something that actually interests you. What interests you? What piques your interest? What is it about? And it might be something that's really peripherally related to the field of otolaryngology or the practice of otolaryngology, but you're still going to be able to be animated about it and educate the people that are interviewing you about it. So I'm sorry I can't give you a research project, but one of the people I interviewed recently on my podcast described it as a pebble in the shoe. What puts a pebble in your shoe? What puts a pebble in your shoe that you want to see go away? So look into that, right? What are your pain points that might be in some way related to your field? What are some of the pain points of some of the people that you're seeing practice, right? Your mentors. Ask them about their pain points. And maybe that'll give you some direction in terms of finding research. Yeah. Any other questions?
Well, I think that wraps it up in terms of the questions that our audience has. I would also like to be interested to hear. I know that you answered a question earlier about an interesting or unique case that you've dealt with in your specialty, maybe earlier on in residency or even medical school. Are there any other cases that you can recall, maybe from other specialties or even still including ENT, that you still can recall?
Interesting cases. Interesting cases. Yeah. Yeah. So this will just show you something about the subjectivity of medicine, right? There's no formula here. There's no cookbook here. So I'll see patients sometimes who have throat clearing. Now, this is sometimes the bane of our existence in otolaryngology, because people come in and they're just I've just got this mucus in my throat. Where is it all coming from? Oh, it's postnasal drip. In mucus from the back of your nose, it's going down the back of your throat, and that's what you're feeling. Okay. Your nose and your sinuses are constantly making mucus. They're constantly dripping down the back of your throat, and you're constantly swallowing them, right? That's normal. So postnasal drip is not a pathologic phenomenon. It's normal mucociliary flow. It's supposed to happen. But often these patients are told, oh, that's what it is. It's your postnasal drip. And then they come to us, and often they're told by their friendly neighborhood otolaryngologist that it's reflux. So reflux is, I don't know, maybe 20, 30-year-old diagnosis in my field. And the idea is that acid from your stomach goes into your throat, and it can cause throat pain, throat clearing, hoarseness. They've actually found pepsin in the middle ear of a quarter of kids with middle ear infections. So it can cause inflammation all the way up into the eustachian tube. And there's some ear, nose, and throat doctors that think that reflux is the cause of everything. Causes head and neck cancer, causes adenotonsillar hypertrophy, causes sinus infections. It causes everything. And then there are those of us who are like, wow, you guys are really sounding the alarm here, and we don't think it causes anything, and I barely think it even exists. So there's this wide spectrum of belief. Now, who's right? We don't know. Each has their own body of evidence and experience that proves that they're right. So it's up to interpretation. So I've got patients that come in sometimes complaining about this, been treated for reflux, it's not working. So we'll take a different path. Now, I won't treat them myself, but I'll recommend that they get treated for anxiety. Now, why would anxiety cause postnasal drip, cause throat clearing? One of my partners refers it as pharyngeal perseveration disorder. They throat clear, which makes them throat clear, and they just can't stop doing it. So maybe it's more of like a compulsion, and that's what you're treating. My thought is it's a little different. So I wish this were Socratic and I could like ask you guys questions and have you lead you towards the diagnosis, but I guess this isn't that thing. Anxiety is your threat detection system on overdrive, right? The brain is designed not to thrive. Your brain is designed to survive, to just not die long enough to reproduce and nurture your kids long enough so they can reproduce. But it's not designed for you to lead a wonderful life. It's designed to not die. So that's baseline. But when you have anxiety, now you're looking for threats even more in a pathologic way. I'll let a psychiatrist give me a better definition. But ultimately, you're in fight or flight a lot of your time. What happens to your mucosa when you're in fight or flight? Well, let's think of the opposite. What happens to your mucosa when you're in the opposite, rest and digest? What happens? What happens? You're making more mucus. You're making more saliva. Why? Because you need to digest your food. That's parasympathetic stimulation. Sympathetic stimulation is the opposite. Your mouth is going to dry up. So if your mouth is constantly dry, what's going to happen to the mucus that's left? It's very viscous. So these patients often have dry noses, dry mouths, and they're not complaining about anxiety. They're complaining about this mucus. I have too much mucus. It's actually not that they have too much mucus. It's that they have too little mucus, and that's left is just so viscous and they'll present with throat clearing, but ultimately, and they're told by one doctor that it's postnasal drip. They're told by another doctor that it's reflux. They're told by another doctor that it's anxiety. And who knows who's right? Ultimately, the proof's in the pudding. But who knows if it's just the patient gets better because you're the doctor that saw them last and it's regression to the mean, meaning like they were just healing anyway, or they got better because there's the placebo effect, or maybe you were actually correct and we never know. So the interesting thing about that is patient comes in with the same complaint, sees 3 different ear, nose, and throat doctors, gets 3 completely different diagnoses and management strategies.
All right. Well, definitely an interesting case and consideration to have, especially for the audience we have here. One thing also I'd like to discuss is how you were at Georgetown when you have your residency. You were appointed as the administrative chief resident. So how was your time as the administrative chief resident for those who might be interested in taking a chief residency year? Maybe they'd like to hear more about how that was, what your roles were, what your involvement was, how that contributed to your experience later along the line as an attending.
So chief resident is different for medicine and pediatrics and probably family medicine than it is for the surgical specialties. So the title means different things. So when you're, say, a pediatrician, you're done with your pediatric residency, you stick around for a chief year, you're getting a significant bump in pay, you're getting a lot of admin responsibilities, and you're ultimately like a junior attending. But in the surgical specialties, you're still a resident. So there were 3 people in my residency program per year. When it was time for me to be in my 5th year of residency, which is your chief year, everybody's a chief resident, but one becomes the administrative chief, which is a blessing and a curse. It's a blessing because it's a compliment that they chose you instead of your peers to have this additional responsibility, and it's a curse because it's a thankless job. You get additional responsibility with no benefit. It did not prepare me for anything. I was stuck making call schedules for everybody, training the students. I mean, I did spend a lot more time with the medical students. It was my job to prepare them for their clerkships, especially those that were doing the away rotation, like they're basically an audition rotation. Their 4th year rotations with us. My job was to help them prepare their presentations. So it was just another opportunity to interact with the medical students and teach, which was good. But it was a lot of scheduling and such admin work, not anything. Nothing sexy about being the administrative chief resident. I'm sorry.
All right. Well, any last comments of advice for anyone who is interested in going to the specialty, maybe just in general about having a passion for medicine, what you recommend to them for the people who are trying to aspire to that kind of position at the end of their career?
Yeah, I mean, if you're looking to take care of patients, it doesn't. So for me, it was never a calling. It was never a calling. And you're going to be surrounded by people that are being like, I decided when I was 8 that I was going to be a doctor, and that's what I've been doing ever since. You know what? I wouldn't let an 8-year-old make a career choice for me. So I wouldn't let an 8-year-old make a career choice for you either. But if that's what you've decided to do, I want you to reflect on it and think, is that what I've decided to do because that's what I already decided to do and I'm just not changing my mind? Or is this still what I really want to do? And for those of you who don't feel like it's a calling, like I don't like that because I feel like it sets you above other people. like I'm called to this greater purpose. You're not greater than anyone else, right? You do it because you think you'd be good at it and you think you're going to enjoy it, and that's it. And if you don't feel like you're the person that has this calling, but you still think you're going to be good at it and you're going to like it, then do it. If you don't like interacting with people, then there are going to be plenty of, jobs within. You can be a radiologist. You can be an anesthesiologist. You can be a pathologist. There are different things. If you love people, then you're going to want to see patients all day. But, other things to think about is you've got to be okay with the monotony, because I'm not sure if you've heard the term hedonic adaptation, but like everything gets old eventually. Like you buy a new car and you're like, this car is awesome. It's the best. And eventually it's just like your car. It doesn't make you happy anymore. And so that's going to happen in your job. You're going to be doing the same things over and over. And so I think it's important to find things that you're passionate about and continue to pursue them, right? Like, don't have this pre-med thing be your only identity. You have to have outside interests. You have to have outside passions. You have to have things that you're going to be able to talk in your interviews about, talk to your friends about, talk to your family about, talk to your significant other about, that are not just about studying. You have to have I took this in a completely different other direction than I thought I was going to, but I still think it's the right advice to give. And, example for me would be the podcast. Like, I finished my 4 years of undergrad, my 4 years of medical school, my 5 years of training in residency training. And then I got to my job and I saw my exam rooms and I saw my office and I was like, okay, so this is where I'm going to be spending the next 40 years. Great. And it's going to get old. So not that I don't enjoy it, but some people, when they enter academics, they're pushing the envelope in surgery. They're doing new groundbreaking research. They're getting promoted from assistant professor to professor. And if that's your bag, then great. But my thing was the podcast. I was like, I'm not great at interacting with patients. I really want to get better at it. I want to talk to people who know about these things. And a lot of them were dating coaches and executive coaches and sales coaches and people that are teaching them how to interact with people, but they weren't teaching doctors how to interact with people. So I have them on my show, and it helps me reinvent myself. It helps me continue to expand. It helps me have something interesting to do, to look forward to, that I haven't adapted to and, incorporated in my life. So it's something new. So hedonic adaptation. I'm actually going to be interviewing someone tomorrow who's practicing in Australia. She was trained in America. She's an OBGYN, and now she's practicing in Australia. She's also practiced in New Zealand. So this is all new and exciting for her. So a lot of times with your training, like, there are going to be things that are new and exciting because you've always got this next step. But also it can get old. Like, there's this running joke, right? Oh, you're living the dream. You see your friend on call. You both got woken up at 3:00 in the morning to come to the ER and see a patient. And you're like, how's it going? Living the dream, huh? Yeah, living the dream. This is what we did all this, training and hard work for, right? You're going to have those moments. So there need to be other things in your life aside from medicine. And they'll also help you be a better doctor, right? Nobel Prize winners are more likely than their peers to speak multiple languages or play instruments or have other interests. So it gives you another way of thinking. So I'm not sure if that's what your question was, but that's my last bit of advice. If you have other things that you're passionate about, pursue those too. Don't abandon them. Keep them as part of your life, and don't let the 8-year-old make the career decision for you. That's what it was. It was the calling. If you don't have this calling, like in the back of your brain, this is what you have to do, it doesn't mean that this isn't the right thing for you to do. Just because everyone around you seems to be like, this is what I've wanted to do my whole life. You can still make a great doctor.
Definitely. I think that's some last words of advice that everyone can take to heart. It's definitely something that speaks to the overall big picture of everything, and being early on in our journey, I think we can all leverage that. So I think that wraps up today's session. Thank you so much, Brad, for taking some time to join us today. And for our audience, to receive a certificate for this session, you must pass the quiz on our website, which is now uploaded. Be sure to join us for our next virtual shouting session with Dr. Hamilton on November 3rd at 7 p.m. Central. Thank you again, Brad, for joining us today, and hope everyone has a good night.
Sorry, who's the next speaker?
Dr. Hamilton.
Barbara Hamilton?
Yeah, I think
Oh,
so.
she's amazing. Definitely tune into that one. She's fantastic. Yes, don't miss that one.
Absolutely. All right. Thank you so much, guys.
Thank you so much, Ted. And thank you, everyone.